everyone, my name is Ophelia. Welcome to this video on the practical use of antibiotics for urinary tract infection. In this video, I'll aim to go through 3 common case scenarios I have encountered throughout my practice as a junior doctor and aim to share some insights as to how to approach these common scenarios. My aim is to help answer some common questions and guide junior doctors in making decisions of when to best commence antibiotics. Now, I'll just start off with some objectives. So firstly, it's to recognise the signs and symptoms of urinary tract infections. Secondly, indications to perform urinalysis and to help diagnose a urinary tract infection. Thirdly, interpretation of urine microscopy culture sensitivities. And lastly, indications of when to commence antibiotics. I'd like to emphasize that this video is only a guide. Always refer to the therapeutic guidelines for any updated information regarding this topic, and ask your senior colleagues for advice if unsure. Alright, let's start with the first case. So you see a Mrs. BB. She's a lovely 88-year-old female from a nursing home and tells you that she's been incontinent and has been needed to go to the toilet more frequently, especially at night. Her past history includes heart failure diagnosed 6 years ago, type 2 diabetes, osteoarthritis, depression, and mild dementia. So before you jump into any conclusions and start treating her as having a urinary tract infection, try and think about other common mimickers which can cause alterations in frequency or nocturia. So for example, in Mrs. BB's case, could she have mild dementia and could she be drinking more at night leading to nocturia? With her diabetes, could she have poorly controlled diabetes leading to polydipsia and increased urination? And always think about the medications that she is taking and do a medication review. So things such as diuretics can cause urinary frequency, hyperglycemia from her diabetes, and also antipsychotic and antidepressants. They can cause, the anticholinergic effects can cause urination and frequency. So keep these things in mind when you're listening to a patient. All right, so what are the signs and symptoms of urinary tract infections? Well, symptoms are more subjective things that patients tell you about in the history. So a very common history that you'll get from patients is complaints of dysuria or pain on urination or burning sensation. That's a very common symptom. Other things is that they might complain of more frequency. And with frequency, when patients are urinating small amounts all the time, it suggests that there may be a bladder wall irritation, so it might be a sign of infection. Or nocturia, or the main thing to keep in mind from history is any acute change from normal is the most important thing you should take from the history. All right, so we'll go to the signs now. These are more objective measures and they're things that you can take on examination. So you probably elicit suprapubic tenderness or even costovertebral angle tenderness, which may suggest a pyelonephritis or infection going up to the kidneys. And always be aware of more systemic symptoms such as fever or decreased mental status. So could, especially in elderly ladies, if they have worsening confusion, that could be a sign that they might have a urinary tract infection. And especially rigors and chills, because that is a sign that they may have more systemic urine infection. And also maybe in the urine, they might get more foul smelling or even cloudy in the urine. And I'll talk about that a bit more later. So we do a urine microscopy culture sensitivities. And when do we do it is one of the main questions. So when a patient is symptomatic with dysuria or any acute change of normal, you should perform a urine MCS and send it off before, and especially for those that have, you should send it off especially before starting antibiotics in patients who are more high risk of getting urinary tract infection and having more resistant organisms, especially those in aged care facilities, people who have had recent antibiotic use, people who have had urinary tract infections and they still have those symptoms despite being on antibiotics, people who have recurrent infections, people who have a history of international travel in the past 6 months, pregnant women who can get complications even though they have to the fetus if untreated, and in men because they're more complicated infections. So always send a urine MCS off before commencing antibiotics in these groups, but when you are commencing antibiotics on someone who is symptomatic for urinary tract infection, always send it off as well so you can get the sensitivities and ensure they're on the right antibiotics. All right, so when is it diagnosed that a patient does have a urinary tract infection? Well, it's an infection if they have greater than 40 times 10 to the 6 white cells, or if they have a large bacterial colony count of times 10 to the 6 and the patient is symptomatic. With patients who have cultures that come back as having no growth in 24 or 48 hours, it usually indicates there's no infection for the patient and that you can stop the antibiotics if they were on antibiotics. All right, so with Mrs. BB, going back to the case, we did send a urine MCS off and this is what it showed. So 100 times 10 to 6 white cells, 1 times 10 to 6 erythrocytes, lots of bacteria and lots of squamous cells. Now, what does this mean? Well, you can commonly get erythrocytes in urinary tract infection, but definitely suggest that she does have a urinary tract infection looking at the leukocytes and also the bacteria. Now with squamous cells, what squamous cells means is it gives you an indicator of whether the sample was contaminated or not. So the less squamous cells you have, the less contaminated the sample is. So even though there's a lot of squamous cells, we know that Mrs. BB is quite symptomatic. So we would decide, so what would you do? Well, in this instance, we would treat her because she is symptomatic. And usually with treating a patient, look at therapeutic guidelines, but usually for women, non-pregnant women, it's a 3 to 5 day course of antibiotics. And for men, it's usually a 7-day course in uncomplicated urinary tract infections. And currently the first line for antibiotics is trimethoprim, but always bear in mind the patient's allergies or whether they've had a particular reaction to a particular antibiotic before deciding, and always ask the patient because then you can decide the best antibiotic to commence them on. Okay. Now, what about catheterized patients? Well, if patients are catheterized, you only treat if the patient is febrile and unwell, because there's no need for antibiotics if they don't have any signs of systemic infection. With catheterized patients, it's quite common that they can get some irritation and feel a bit of dysuria because they do have a foreign body in their urinary tract. But if they are febrile and unwell, the main management is to take a sample, urine MCS, and change the catheter before commencing antibiotics. Now, once you get the urine MCS results back, if then If there's no growth at all, then you can stop the antibiotics. But if there is growth, await sensitivities and change the appropriate antibiotic. Commonly, dysuria in catheterized patients, it can be caused by candida, and evidence shows that it says that the use of antifungals won't resolve symptoms and has not been shown to improve outcomes, so it's generally not recommended. All right. Another common question I've been asked on the wards is whether to commence antibiotic prophylaxis post or prior IDC insertion. Now, I looked around various evidence pools and literature reviews, and there's no evidence that it decreases pyuria in the bladder, so it's not generally required unless they're in high-risk patients who are at risk of urosepsis or if they have a prosthesis. The reason why is that it can compromise the healing process and the result of the prosthesis. So there are different thoughts in the prosthesis setting, so it's always best to ask your consultant in that instance whether it's appropriate or not. All right, so let's go to the next case. Okay, case 2. So Mrs. BB comes back to you now, and she states that she has cloudy and stinky urine 6 weeks later after you've treated her for her urinary tract infection. Now, you do a urine dipstick, and it says it's positive for nitrites and leukocytes. Now, would you treat or investigate for that? Well, it doesn't really require any investigations or treatment, because what leukocytes show is where you have a urinary tract, there's an inflammatory process going on in the urinary tract. And it may be due to urethritis, not suggestive of a urinary tract infection alone, if you get that. And always be aware, though, in another point to remember in sexually active women, that those that have urine dipstick positive for leukocytes, consider, and if they have some dysuria and still when you send off the urine MCS it comes back as normal, always consider chlamydia urethritis, because that doesn't usually show up on urine cultures. All right, and what about nitrites? Well, nitrites really strongly do suggest a urinary tract infection, but it doesn't exclude it. Why is that? So why do we even use nitrites? Well, nitrates are reduced to nitrites by gram-negative bacilli, which is in groups such as E. coli. And that's why we use nitrites. And with the gram-negative bacilli, they're very sensitive to gentamicin. Now, why is it why doesn't it exclude a urinary tract infection? Well, it's because it's not reduced by gram-positive uropathogens. So other things that can cause urinary tract infection, such as Staphylococcus saprophyticus or Enterococcus bacteria. And with these bacteria, they're more susceptible to ampicillin instead of gentamicin. And also be aware it's not produced by chlamydia. Okay. So another point to be aware is that nitrites can be sensitive to air. So a third can give false positive results after 1 week, and 75% can give false positive results after 2 weeks. So always check the expiry date of the dipstick and make sure you store it in the correct way when you use it. All right. And I've got and urine dipsticks has been shown to correlate well with very high bacterial count urinary tract infection. But just to be aware, it is a screening test, so you can miss those who have lower bacterial counts. And this can be up to 20% of patients. So just be aware of that, and always send a urine MCS off, even if it is negative. Now, I've got another common question on the wards that I wanted to share with everyone. So usually you might get nursing staff that come to you and says the urine dipstick lights up like a Christmas tree. Now, what do you do in this instance? Well, in this instance, it's quite good to try and clarify with the nursing staff what they exactly mean by lighting up like a Christmas tree. What is actually positive on the dipstick? And after they have told you, look at the clinical context of the patient and the status of the patient. Now, do they have ketones because they've been fasting? Do they have glucose because they are diabetic? Do they have protein in urine due to an underlying renal disease? So just to answer that question, clarify what they mean and what is positive, and look at the patient themselves and treat the patient, not the dipstick itself. And if you're unsure, always send the urine MCS off. All right, so back to the case after a little bit of divergence. So you send the urine MCS off, and this is what comes back up. So you've got a lot of leukocytes, lots of erythrocytes, a little bit of erythrocytes, lots of bacteria, and not much squamous cells. So as I mentioned before, there's not much squamous cells, so it's not contaminated sample. Now, but she's not symptomatic of a urinary tract infection this time. So what does that mean? Would you treat? Well, this is what's called an asymptomatic bacteria. And it's defined as a colony count of 10 to the 6 in a patient without any symptoms. It's very common in the elderly, and evidence suggests that around 20% of elderly women in aged care facilities have asymptomatic bacteria, and it's not associated with increased morbidity. So it occurs frequently, and there's no benefit for treating this. So a diagnosis of a urinary tract infection in this age group should be on the clinical signs and symptoms in conjunction with culture results, rather than just the dipstick alone or just the culture alone. So what would you do? Well, main management for her is to observe her in 24 hours, as they may get better. And if she develops symptoms later on, then commence her antibiotics. Now, when do you treat for asymptomatic bacteria? Well, this is important to treat in pregnant women and those undergoing urological procedures, because they have an increased chance of developing a urinary tract infection and also a resistant organism, and having complications such as for the fetus itself. So in those instances, you would treat if they're having asymptomatic bacteria. All right, so we'll go to the last case now. So Mrs. BB comes to you again after having a few more cases of urinary tract infections, and she asks you how to prevent them from occurring in the future. Now, what can you do? All right, so this is just a list from the therapeutic guidelines, so it's not an exhaustive list, but always ask for some senior advice if you are going to commence these things. So first thing you can use is topical vaginal estrogen in postmenopausal women, and it has been shown to be effective in preventing recurrent urinary tract infections. You can do what's called an intermittent self-treatment, which is giving a patient a script of 3 days of antibiotic therapy and tell them to commence it when they start getting symptomatic of a urinary tract infection, and if the symptoms don't resolve, to go and seek some medical advice. And the last thing is having patients on continuous antibiotic prophylaxis after you've successfully treated their initial urinary tract infection and confirmed it with culture. And in this instance, you only consider it in women who have had frequent symptomatic infections of greater than 2 or more infections in a 6-month period, because there are risks also in having long-term antibiotic use, and these risks include vulvovaginal and oral thrush, gastrointestinal symptoms, and also the development of Clostridium difficile infection. Okay, so that ends my talk. I just wanted to share with you some take-home messages now. So firstly, always consider other common causes or mimickers of urinary tract infection before you jump into treating someone. Only do a urine MSU if the patient is symptomatic with any symptoms of an acute change from normal, or if they're high risk of getting a urinary tract infection. Only treat patients who are symptomatic and have a positive urine culture, apart from those who are high risk. And don't treat in all catheterized patients unless urine cultures do suggest they have a urinary tract infection. And be aware in the reading of a urine dipstick, as I mentioned in the video, and avoid treating asymptomatic bacteria in the elderly, as they often resolve their symptoms over 24 hours. And always refer to therapeutic guidelines and ask your consultant if in doubt. Now, I've also included a few great resources I have come across throughout my talk, so please look at the summary page for details. Thank you very much for your listening and your patience. I hope this video helps you.